All attendees are in listen-only mode.
Good evening and welcome to Reproaction's August 2017 Act and Learn webinar. Tonight's topic is very special and important. We will be talking about taking action on maternal and infant mortality. So who are your hosts? The co-founders and co-directors of Reproaction. This first voice you're hearing is myself, Erin Matson. I am based in Arlington, Virginia.
And this is Pamela Merritt, and I am based in St. Louis, Missouri.
Great. All right, so let's go through the agenda. First, we're going to introduce Reproaction. Then we'll go through an overview of maternal and infant mortality. Then we'll talk about Reproaction's maternal and infant mortality campaign. We'll have a panel discussion, and tonight our panelists are Marcia Jones, Dr. Joya Clear-Perry, and Robert Turner. We'll talk about next steps, and then we'll do a Q&A with panelists and or Reproaction co-directors. So if at any point during this presentation you have questions for any of the panelists or the Reproaction team, including the co-directors or Ivania Woods, who will be joining us tonight, just chat those in the chat box. Pamela, I'm going to ask you for your help. If you could please make Ivania and Robert panelists. I'm having some difficulty doing that now that the presentation has started.
Will do.
Thank you. All right, so introduction to Reproaction. So Reproaction is a new direct action group forming to increase access to abortion and advance reproductive justice. You wouldn't believe how proud we are of our left flank analysis that we bring to the work. Specifically, we have a willingness to hold people on all sides of the issue accountable, whether they're traditionally considered allies of reproductive health rights and justice or opposition of reproductive health rights and justice. We have a deep commitment to nonviolent direct action as well. And then I will pass it over to Ivania to get us started. And Pamela, I just also like to ask if you see Dr. Joya come in, please bring her in as a panelist as well. Thank you.
Will do.
Great. So, Ivania, are you there?
I am. Can you hear me?
Yep.
All right, great. Just FYI, the PowerPoint has not changed at all. Just FYI. So our maternal and infant mortality campaign started a few months ago in April here in Missouri. It started out at the state capitol with documentary screening. Fusion TV Network was nice enough to authorize us to use a documentary that they produced. They sent us a DVD copy, information from the screenings that they did, and we did that and have been scheduling more screenings throughout the state. So right now we have another one coming up in Jefferson City. We have one here in Columbia where I reside next week. We have one in Charleston, Missouri. We have one being planned in Springfield, and Joplin, Kansas City, and St. Louis around the state for the screenings. And the basis around that is kind of just to focus on getting community people involved, spreading the word, giving people a platform to speak of. And since Reproaction is a direct action organization, and we'll be mainly focusing on, like this webinar, taking action, like how can we address these issues. And so the campaign thus far is has been built on that perspective, and here in Missouri, and tying it into our crisis pregnancy center work. So going back to that is what is and why should we care about maternal and infant mortality? Well, the maternal mortality rates here in Missouri are on par with the national rates. We actually have in the United States, we spend the most per capita on healthcare than any country in the world, any nation in the world, and we are currently ranked for the latest ranking at 169th. So we're number one in spending and 169th in our maternal and infant mortality rates, which is quite pitiful, if I may say so myself. And infant mortality rates refer to, the deaths of children under 1 year of age, and of course, maternal mortality rates are due to deaths of pregnant people due to pregnancy-related complications. But both of these are indicative of the health and well-being of a nation. So when we talk about infant mortality and maternal mortality, those are like the canaries in the hole. So if you want to see how well a country is doing, country leaders usually look at the infant mortality rate of that destination, and we're doing very, very poorly for a variety of different reasons. And so, yeah, that's my spiel. Was I within time? Was good, right? All right. So more about our campaign. Beyond the screenings, we've had some things come out from that. So with everyone's excitement throughout the state on the campaign, it's branched out into a couple of different things, and I am currently working with Columbia area midwives. There are 5 of them, and working with them to help address maternal and infant mortality by closing the healthcare gap in rural areas of the state. So since our governor has not expanded Medicaid, our previous governor didn't expand Medicaid, we don't have Medicaid expansion in the state of Missouri, we just had a huge, massive budget cuts to all things here in Missouri, and that definitely affected healthcare. I believe, if I'm not mistaken, we got like a 3% cut. We've had, I think, 3 rural hospital closings here in Missouri. And as with most states, most of Missouri is rural. And so what we're trying to do is target this campaign around and center it around the health disparity that Black women face, women of color. And, as you may or may not know, Black women are 3 to 4 times, on average, 3 to 4 times more likely to die from pregnancy-related issues than white women. And so the numbers in general are horrible. But then when you factor in race, it becomes even worse. So since we are a direct action campaign, like I said, we have tied it into our CPC work. And CPCs are crisis pregnancy centers. The way that crisis pregnancy centers are funded here in Missouri, they're funded through block grants that the federal government gives the state that's supposed to go to feeding mothers and children, people that are far, far below the poverty line. So these are your most destitute, your poorest, your most poverty-stricken people. Well, while the governor was making all of his cuts, he did not cut that funding to crisis pregnancy centers. So they're basically taking money that's supposed to go to feed hungry children to fund these crisis pregnancy centers. And these crisis pregnancy centers don't do anything to address maternal and infant mortality. They're not even real clinics. They don't have any licensed people, licensed physicians at these clinics. So we've worked on that. We have a petition that you can sign that's on our website, reproaction.org. We've had Twitter actions. Our hashtag is Death by Delivery Mo, which is for Missouri. And we've had several protests in Columbia and St. Louis, and those will be expanding out as well. And also educational initiatives, giving out information for people on maternal and infant mortality so that they know what this is, inviting them to our screening so that they can come and discuss it and learn more information about the severity of the issue and how the severity of this issue affects our communities. And so I will pass it back to Aaron and Pamela.
Thank you so much, Eva. So this is Pamela, and so I'm proud to introduce Marsha Jones. Marsha, are you there?
Yes, I'm here.
Fantastic. So a bit of an intro for Marsha. Marsha is the co-founder and executive director of the Afaya Center. Marsha Jones is a Texas native, and she also graciously serves in leadership positions with multiple state and national groups and organizations doing reproductive justice work. So thank you so much for joining us, Marsha.
Thank you all for having me here and having the here.
No, thank you. Thank you. So let's kick it off with a question. So why do you work on maternal and infant mortality?
So we work, so there's a couple of reasons why we work on maternal and infant mortality, very specifically how this impacts Black women. So we do this work at the Afaya Center because we feel like that it's just every woman's right to have accessible, affordable, safe, and respectable maternal health. We believe that that's right, that should happen. And we do this work in Texas Unapologetically Black because it's not happening that way here. We talk about it a lot. We talk about maternal mortality, we talk about abortion access, we talk about all of this stuff. But for the better part, these conversations have not been historically led by Black women. And so it just becomes very important to us at the Afaya Center that voice is lifted and that voice is heard. And so, but also we do this work because we discovered that maternal mortality is one of the leading causes of death among Black women in the state of Texas, which is that should not be. We also learned that there's little understanding as to why this phenomenon exists, except that the women are Black. And we've discovered in talking about these issues that impact women in Texas that, for the better part, people are not even aware that this is happening. Like we're talking to people every day who have no clue that women, for one, Texas, we hold the number of having such a high rate of maternal mortality in the state, higher than any other state, and especially how it impacts Black women. But people don't know it. Like there's even politicians, like community leaders in our state and in our city who had no idea that this was happening. And then we just want to ultimately put an end to these deaths. We need to end this just because we want to make sure that, just like we believe that women have the right to not choose to have children, but for those women who choose to be pregnant and carry a pregnancy to full term, that woman also have the right to expect to live.
Mm-hmm. Absolutely. So to follow up on that wonderful explanation of your work, what have y'all found contributes to the racial disparities we see in maternal and infant mortality rates between white and Black babies and Black women?
Would you repeat that question for me one more time?
Absolutely. So have you found any contributing factors? What do you think plays a role in the racial disparities that we see?
Okay, so that is the role. I mean, race. When you look at what's happening here, for the better part, it is the only difference is Black and white. I mean, it just boils down to how Black women are historically treated when we enter the care system. What happens throughout that time we're in that system, and it boils down to just the basic color of our skin. That's it. It's just systemic racism that drives what's happening here. I mean, we could look at that not just for maternal mortality or these issues, but HIV, any health disparity, any issue that's happening in this state or across the country. But I know here that main thing is color. It boils down to the color of people's skin and how we are greeted when we enter the healthcare system.
interesting. So just to continue on that, so how are Black women and women of color greeted when they enter the healthcare system? What are some of the reproductive oppressions that that women of color and Black women face?
So some of the reproductive oppression that women of color or Black women in our state face, there's environmental justice concerns, birth justice concerns, the way we're eating or the food we have access to, food deserts, those basic systemic biases that come into play, and access to insurance or access to health care. And so for the better part, where and how women are living, the conditions that these women are living in, sometimes is horrible. And even having access to, living in places where you have to travel on the bus for hours, or just insane amount of time just to make it to your doctor's appointments or things of that nature, where those birthing centers and things like that are not in the communities right there where you live, and opposed to across town. All of these things are almost like across the street. Birth justice concerns, Black women, for the better part, are not offered the same type of accommodations that white women are offered. You were offered, even if it's like when you're looking at cesareans or whatever, sometimes Black women are still offered more evasive procedures for having children when it's a cesarean, or not given the opportunity to go as far as you can go to ensure that you have a natural birth, and opposed to, bam, we see a problem, let's do cesarean right now, let's make it be evasive, as invasive as possible. Black women not having access to doulas, not having access to the benefits of midwifery, and not having those kind of classes made available to them, like immediately when they come into the clinic or present pregnant, being connected with those services like midwifery and doulas. And then when we look at food deserts, how we eat the food that we are being offered. So many times, Black women and these women, these very marginalized women, are still eating from the corner store. There's no store in your general area that's where you can get the best food possible for them at that time. And even what when they go to the doctor to be pregnant, and we're talking about nutrition, are they really having those nutritional meanings, or do we just like fly by night there? Yeah, you're pregnant, you're 5 or 6 months right now, we're going to schedule with a nutritionist, or it's up to you to get scheduled with that nutritionist? Is there any real serious follow through to make sure that this woman don't fall in the crack? And then access to insurance and health care, well, that's another whole thing, because we have a consistent legislative body here who have said from the very onset that they are not going to expand Medicaid and Medicare. And so these women are coming into care, getting these services. They're coming into care without any kind of health care or insurance, and they're only getting this when they're pregnant. And then soon after the baby is born, they lose it.
Mm-hmm. Mm-hmm. Wow. It is amazing how common those disparities are across states that also have very high infant and maternal mortality rates. So I have one more question. I really want to find out more about what your organization is doing in Texas. Texas has been in the news a lot about with reports about the high infant and maternal mortality rates. So what are y'all doing right now to address those rates?
Well, the main thing that we're doing right now is really our biggest piece is getting the word out. Mm-hmm. And so to get the word out, we had a really amazing online digital campaign that went out that had a copy of, so let me back up. So on May 25th, before the end of our legislative session, we had opportunity to present a report on the state of Black women in Texas, and we centered in that report we centered in that report maternal mortality and what those numbers were looking like for Black women in Texas. So that's a really big piece that we did, getting that report out and getting that report into the hands of our legislators. Black, white, Republican, Democrat, didn't matter. Across the line, we got that out to everybody. Partnering with one of our legislators, Representative Theory, in working to really get some legislation passed that would really target those women who are most impacted in Texas by this maternal mortality rate, which for Black women, it didn't pass through the regular session, but we were successful in getting that bill passed in the special session. And so we worked really hard to do that. So those are the three top things that we've done. So we have now connected with organizations here in Dallas. Community Action Network One, which they're very specific to looking at infant mortality in Dallas. Also, we have relationships with the Texas State Working Group on both infant and maternal mortality. We're developing relationships with birth justice organizations in Dallas, and we are working to create a task force here in Dallas that will identify what's happening, because we still want answers. We just don't want the data. We want to know. We're really clear about what probably is leading this, but we want some really data. We want some hard data that will lead to some end results, and that's ending this overwhelming number of deaths. So we're doing some on-the-ground advocacy work. We are searching high and low for families who are now taking care of these children who were left orphaned by their mothers who died, and getting their stories and giving them an opportunity to tell their story so that people would know that this is happening. Those are some of the things that we're doing, like really educating our community. We are making relationships with legislators in the city, and on our city legislators, as well as our county legislators, as well as our state legislators, so that we can continue to move legislation that will address not just the maternal mortality rate, but the conditions that set the maternal mortality rate into play, like the environmental, birth justice, food desert concerns, and the systemic biases that already exist. So these are some of the things that we here at the AFIA Center that we're doing, that we will continue to do until we see an end to this.
Fantastic. I'm forever amazed by you, Marsha Jones, but thank you so much for explaining your work in Texas. We have your website up on the screen, theafiacenter.org, and you can follow them on Twitter. I recommend very strongly that you do, because some amazing reproductive justice work is going on. Marsha, if you'll stay on the line, we are going to move on to our next panelist, and then at the end, we're going to have a Q&A. So to attendees on the line, if you have questions for any of the panelists, please drop them into the question tab that is on your GoToWebinar control panel, and we will collect those and ask those at the end of the presentation. So Marsha, thank you. And without further ado, I'll turn it over to Erin.
All right.
Thank you.
Thanks, Pamela. And do you have Dr. Joya unmuted as well?
I think I do. Are you there, Dr. Joya? Dr. Perry, are you on the line?
Oh, Dr. Joya Career Perry, are you there?
We're having technical difficulties.
Let's see here. I would suggest that at this point, if we're unable to get Dr. Joya Career Perry unmuted, that perhaps we could move on to Robert, and I will reach out to Eva to see what I can do.
Perfect. Sounds like a plan. All right, so moving along, and I apologize for the technical difficulties. Our next panelist is Robert Turner. Robert, are you there?
Yes, can you hear me?
I sure can. So Robert is the project management coordinator for Boot Hill Babies and Families, and that is in Southeast Missouri. His responsibilities include guiding a community-based steering community on strategy and implementation of that strategy, and that is boothillbabies.org, and you can also follow them on Twitter. Welcome, Robert.
Thank you for having me.
We are more than pleased to have you. So let's jump right in.
All right.
So tell us a little bit about Boot Hill Babies and Families.
Sure. So Boot Hill Babies and Families is an infant mortality reduction initiative. We work to partner with organizations and agencies and local health departments, local hospitals, community members, any individual who considers themselves a stakeholder in the health concerns of the Boot Hill. And when we say Boot Hill, we're actually not referring to the entire Southeast Missouri region. We're referring to 6 specific counties. There are the southern most counties in Southeast Missouri, and at the top of that area is Scott County, and we go all the way down to Pima-Scott County, where we're at the Tennessee-Arkansas border.
Got it. So could you just give a quick overview of what is the health outcome? What are the infant?
When we began in 2013, and we've seen some change in that number since then. So in 2013, our infant mortality rate was actually sitting at 7.2 for the Boot Hill region. Since then, we are at 2016, and we have seen a rise and then fall again from 9.1, and now we're all the way down to 8.4. Our goal is to get it to 7.9 by the year 2022. That's the goal by standards of our grant, but obviously we are working to, in essence, eradicate infant mortality to the best of our ability.
Got it. So what are some of the projects or campaigns that you feel have contributed to improving those numbers?
Sure. So one thing about the Boot Hill of Missouri in terms of our infant mortality issue is that the majority of our infant deaths come from safe sleep issues. So what our steering committee and our community experts decided to do was to, of course, focus in on safe sleep issues first. So we, in partnership with our marketing group and our community liaisons, began an ABCs of Safe Sleep campaign. We pushed hard on social media. We pushed hard with billboards. We pushed hard on television. We were creating Google ads, so really trying to get us out there digitally. And then we were also out completing listening sessions in the community where we doubled those listening sessions as educational moments. I'm not sure if anybody on the webinar is familiar with baby boxes or boxonettes. They're kind of controversial, but that was one of the things that we also did. We partnered with our local hospitals and local health departments and our local Healthy Start organization to distribute baby boxes and safe sleep education to new mothers and families in the area.
And for our listeners who aren't necessarily familiar with safe versus unsafe sleep habits and protocols, could you just explain a little bit what you mean by safe sleep and what are some of the unsafe sleep habits that contribute to infant mortality?
Sure. So I'll start with unsafe sleep. So what we characterize at Boot Hill Babies and Families as unsafe sleep is anytime you put your baby to sleep on his or her stomach, anytime that you put your baby to sleep in a crib that does not have a fitted sheet, anytime that you put your baby to sleep in a crib that has loose bedding or choking hazards. So we use the ABC model, which just basically means that your baby should be asleep alone in a crib, on its back in a crib, or other safe sleep surface. So that's our A, B, and C.
Got it. Awesome. So, and then just for folks who aren't familiar with baby boxes, could you kind of explain that? Maybe a visual explanation of what their purpose is and how they came to be.
Sure. So they actually originated in Finland. Finland was notorious for having a very high infant mortality rate, and so they introduced these cardboard boxes. I and they were mainly designed for families who were under the poverty line and couldn't afford suitable bedding for their infants. And so they're basically these cardboard boxes, and there's a thin mattress that you put inside of that cardboard box, and it works for a baby up to 3 months, or until, depending on the baby. We've seen some babies outgrow that box in about 2 months. But you use your best judgment as a parent, and you work with your team. We have a lot of community health workers who go into the home. So you work with those individuals to decide when it's time to transition your baby from that box. But there's a fitted sheet in there. It's pretty safe. It's cardboard, of course, so you don't want to get it wet. But we use that as a quick response to a mom not having a safe sleep surface. So what we don't ever want to see, and what I've walked into homes myself and seen, are infants on a blanket on the floor. So in a situation like that, we would work with the local health department or distribution agency appropriate for that area to get that mom one of those boxes until we could find a long-term safe sleep surface.
Got it. Thank you very much. So you talked about this a little bit, about your goals moving forward. So if you could just expand on that, that you have seen an improvement in infant mortality. So when you think about the work that your organization is doing, what are the goals of the organization, and how do you see the direction of your organization moving forward?
So our overall goal, like I said earlier, is to increase or decrease infant mortality by 15% over the course of 10 years. We began in 2013, and we extend out to 2022. And so that's our large goal. Now, what we do to reach that goal is we work in 3 main focus areas: safe sleep practices. We focus in on pre and postnatal care. And then we also focus in on infant deaths due to substance misuse and abuse in the home by parents. And so we're working with anybody who wants to work with us, basically creating a culture of collaboration across the area to educate and to be able to empower those families and parents to make better decisions, which in turn increase the likelihood of positive health outcomes for these infants.
Got it. So I'm a Missourian myself. I live in St. Louis, Missouri, and I know that we city folk often have some pretty big stereotypes about rural parts of the state, even though we have a lot in common, unfortunately, including infant and maternal mortality rates that are off the charts. So when I think about people who are doing work in rural parts of the state, I'm always curious about what motivates you to work on infant mortality rate in the Boot Hill, in the southeast part of Missouri.
Sure. So I'll backtrack a little bit to frame this question, or to be able to frame my answer a little bit better. I'm originally from Detroit, Michigan myself, and I also grew up in St. Louis. And I moved down to the Boot Hill following my undergraduate career and began this work. However, what mainly motivated me to get into the work was that we see the same things. So the same numbers that we have in the Boot Hill in terms of our infant mortality rates, they look very similar in Detroit. They look very similar in St. Louis. And what I know about nonprofit funding and public health is that, particularly in Missouri, public health gets kicked to the back. That's where the money goes last, and we all know that. Another thing that I know about nonprofit funding is that rural areas typically get the last or the least. And so that's what particularly motivates me. Now, what motivates our team to do the work that they do in our steering committee is the need that we see in the area. The Boot Hill is suffering from the same issues that most other rural areas are suffering from that have issues with infant mortality. That looks like a lack of access to health care, inadequate health care, and then some cultural and structural barriers that greater motivate us to do the work. And more than that, the racial health disparity in terms of infant mortality is ridiculous in our area. We're looking at, for example, in our 6-county region, 1,224 births to white mothers, and we have 7 deaths. And that's a very small percentage when you're looking at that overall number. Well, when you look at the same statistic for Black mothers, we had 294 births to Black moms and 9 deaths. And so that's outrageous, that's ridiculous. And even though we're moving in the right direction in terms of our infant mortality rates overall, that disparity needs to begin to close.
Absolutely, absolutely. So Robert, thank you so much for explaining your work and the work of your organization. So stay on the line, and we'll be coming back to you for the Q&A section. And I'm going to check in with my partner in crime to see if we were able to resolve our tech difficulties.
We have.
I think I'm here.
Delighted to report that we have. So this is Erin. I'm going to take it back and introduce Dr. Joya Creer-Perry, who we're very happy to have us joining us tonight. Dr. Joya Creer-Perry is the founder and president of the National Birth Equity Collaborative. She has served as the head of multiple healthcare facilities and programs throughout her career. She's an authority on this topic, and we're so happy to have you tonight. Thank you for joining us, Dr. Creer-Perry. Are you there?
Hello?
Yes, hello.
Oh, yes. You can hear me this time, I hope. Yes?
Yes, you sound loud and clear. So
Okay.
I'd love to dive in. So my first question for you is, what drives your work on addressing maternal and infant mortality? Why do you do this work?
You know, as an OBGYN, first of all, I want to thank you guys so much for having me on. And I do have a 6-year-old who is trying to be compliant, but he's trying to also avoid bedtime, so he might at any moment become non-compliant. So just letting you all know. But thank you again. First, in the beginning, as an OBGYN, seeing patients day to day, you realize that having them in your office, you can do very little to really all the things that happen outside of their lives and all the things that really impact their outcomes. And so it becomes really critical to start thinking bigger than just one-to-one individual interaction, but really how can we also improve the entire system? What are we doing as a country and as a community that is actually harming Black women and babies, and how can we do better to make sure that we get to live and thrive? And also, as the mother of 3 Black children and having a Black daughter, I can tell you I worry about what would happen to her if she were to decide to have a baby tomorrow. She's 24 years old. I don't know that our system values her in a way that she would survive that pregnancy. And that worries me, and that drives me to make sure that if I worry about my own child with all the resources, knowledge, and information that I have, what happens for that mother who doesn't have the same amount of resource and knowledge and information that I do? And how can I ensure that this place, that our country is doing better for those moms as well and babies?
Thank you. Thank you very much. So my next question for you is, if you could talk about the relationship between maternal and infant mortality. What is the relationship between the two, and why are these rates often discussed together?
Why are they, or why aren't they? Because I could say that. Go ahead.
Both.
Okay, so both, yeah. So I think that they should be discussed together more often, honestly. So if mom dies, the baby has a 50% chance of dying as well. And yet we in this country concentrate so much on babies, and we never think about mom. Honestly, I have to be in my own work. When we started the organization, National Birth Equity Collaborative, about 2.5 years ago, our mission was for Black infant mortality. And we really were very focused on decreasing the disparity between Black and white infant mortality and reframing it from this very personal responsibility laden, if only you people would put your babies on their backs, or if only you people would behave and not smoke, and really thinking about what are the systems and structures that create these inequities in the first place. And then, we had the wonderful opportunity to be exposed to the Black Mamas Matter work and thinking about, and then, the UN's focus on maternal mortality. And this is a great example of how the world understands that women matter and moms matter, and yet in the United States, we don't. And so we make all these rules, and I was listening to Marsha talk about her with the Shia Center and how important it is that we don't just penalize and oppress moms, but also ensure that they are able to have healthy and loved experiences when they are having babies. And so for our work, we're really trying to uplift both the inequities in both Black maternal mortality and infant mortality, because they are tied. And it is the canary in the coal mine for both places. It looks really crazy to the rest of the world that we spend more per capita for healthcare than anybody else, and yet people die in childbirth. They don't even believe. When you're on a panel, when I'm on a panel in Geneva with someone from Uganda, and we can talk about the same kinds of things, different reasons, right? Like we have a lot of resource, but if you choose to put your resources in communities that are already highly resourced, then people will die in the communities that don't. So how we choose to even place resources causes both moms and babies to die. And so that is a system choice, not a personal responsibility or individual choice.
Yeah, I'd love to follow up on that with a question for you specifically. So I live in Arlington, Virginia, which is right outside of Washington, D.C., and I'm sure you've seen the news. I'll explain it to our attendees on the call who may not know that recently the only hospital in Southeast D.C., south of the river, or southeast of the river, so in Anacostia, stopped offering maternity services entirely. So there's now no place southeast of the river for women to give birth. And I'd love to hear your reflections on that and what you think should happen next. At first, the news just broke that they were closing it down. They didn't provide any explanation. Now there's stories starting to trickle out about substandard care. And I'd love to hear your thoughts on that.
Yeah, and I wish I could say that was an isolated thing and magically Anacostia was different from the rest of Black America, but it's not. And so across the U.S., since the Heckner report a long time ago in the 1930s, when it looked Black hospitals that serve in poor communities, what they usually do is shut them down instead of add resources to make them better. And OB is one of those things that costs a lot of money. And so places, because our healthcare system is built upon money and not on valuing people and individuals, they place OB units where they make more money. And so if they run the numbers and show that they are not making money off of labor and delivery, they're going to shut it down. And so that is a basic value system of the entire United States, not just here in D.C. or Anacostia. So across the South, rural hospitals have been closed. We get called a lot about that. Some Black women, in Georgia, part of the big reason that women are dying in childbirth is because of the closure of rural hospitals and also not allowing for midwives to deliver. I mean, another thing specifically around Anacostia, D.C. did a study around transportation and saw that Anacostia also doesn't have transportation. And so it's not every place that you undervalue and every group of people that you undervalue and under-resource will also have fewer access to things. And so Cleveland Clinic sits inside of the neighborhood in Cleveland that has one of the highest rates of infant mortality, but they don't do deliveries at that hospital. People fly from all over the world to come to Cleveland Clinic. They do deliveries in the suburbs where they make money. So that is the nature of the healthcare system within which we live.
Yes, the compound injustices. Thank you for elucidating that. It's really chilling to see it happening in my backyard, and as you noticed, it happens all over this country. So my next question for you is, based on your experience, what do you see as promising ways to address maternal and infant mortality rates in the U.S.? And what would you like to see people's work focus on in these areas?
Yeah, I'm excited about the interest in equity. Say that our little small organization is getting a lot of interest lately, just because I think the reality of our political environment makes people realize we can't run away from the idea of race and racism and its impact on health. And it harms Black people and Hispanic people and Muslims, and it also harms pro-white people, and that's why you see an increase of death. in poor whites and rural communities. And so I'm excited about us even having this open and honest conversation about, well, if we understand this, if we understand that we have a system that doesn't value us, what are we going to do differently? How do we organize around all the communities, around all the issues, and make this really be a cross-sectoral conversation? So how we can tie both, the idea of transportation, housing, criminalization, all those things are all tied to our ability to have babies and have maternal mortality. It's not just a program that needs to give them grant dollars to do home visits, but how do I fundamentally change how we provide resources, such as those we shut down, and how we organize together across issues to make sure that we do that.
Thank you. And my final question for you is, are there any current initiatives you're working on that you would like to discuss or notify our audience about?
Yeah, I mean, I was thinking about this. There's so many. I think specifically there in Missouri, because your organization is based there in Missouri, and we are coming to the Boot Hill to present work. We've also done some webinar boxes, folks there working campaigns. I think anytime that any organization wants to actually look at what equity looks like inside of their work and unpack if they keep doing the programs the same way, why they don't get different outcomes and why the inequities still exist, we're down for being a part of those kind of conversations. It is difficult for people to do. We work with organizations from the New York City Health Department to the Louisiana State Health Department. And it is a complex idea to fundamentally change how you think about, the people you work with, that they have value in the conversation and they should be able to be listened to, and that they should be a part of how you design whatever programs you put together. That is a challenge for most state organizations. That's the only way we're going to get to equity. And then also, once you have invited them in the room, not just using them for the expertise, but actually hiring them in some of the positions that you have available, allowing them to have a decent living wage, making room for new voices and new ideas and people who might not actually look like you to be a part of these larger institutions and health systems, because it is very difficult. One cannot imagine having a health system where all the people were Black, right? So if you were a white person living in America and you walk into a hospital and no one looked like you, that would throw you off. But that's a lived experience for a lot of people of color in this country. And so until we start making room for even hiring people who don't look exactly like how we look, and expanding our hiring practices. So those are some of the other things we work on with organizations, to lean into that uncomfortability and improving their hiring practices. And lastly, just really thinking about, we're working with both large organizations to work on their maternal mortality review process to make them more open to the community. They're usually done very closed, and people don't even know what's going on, and they have no input from the community, and the community is not engaged, and they wonder why there is mistrust. But we're never going to get anywhere unless we start opening those up. And so any opportunity for, if there's organizations that, states or cities who are doing these reviews or want to do more community engagement, those are the kind of things that we believe will be impactful for improving equity and improving birth and infant outcomes and maternal outcomes.
Thank you, Dr. Creer-Perry. And I'd like to encourage everyone with questions to type them into the chat box. I'm now going to move to encourage you all to, if you haven't already, to sign up for alerts for Reproaction at www.reproaction.org. We are on social media. We're at Facebook, Twitter, and Instagram as Reproaction. You can learn more about our maternal and infant mortality campaign on our website. If you go to our homepage, you can either use the link provided, or if you go to our homepage, you can go to Take Action, and it'll be one of the first campaigns you see. There's a wealth of information up there, so we encourage you to check that out. We also encourage you to join the fight against fake clinics. That also, you can do that at humancoalition.reproaction.org, or again, you can go to our reproaction.org, Take Action, and that campaign is also prominently featured. I'd also like to ask everyone to save the date for our next Reproaction Act and Learn webinar. We host these webinars every single month. They're open and free to the public. The purpose of them is to dive deeper into topics of interest to activists and to share strategies and hear what's working and what isn't. Next month's topic will be focusing more deeply on crisis pregnancy centers, specifically using direct action to target crisis pregnancy centers or fake clinics in your community. We're very excited about this webinar. We'll be presenting it in conjunction with our friends from Advocates for Youth, and that will take place on Thursday, September 28th from 7 to 8 p.m. Eastern. If you sign up for alerts at reproaction.org, I promise you'll never miss the invite. And with that, I will pass it to Pamela to moderate the Q&A.
Thank you very much. So we do have some questions, and as Erin mentioned, if you do have questions, just drop them into the question tab on your GoToWebinar control panel. So the first question is actually for Marcia, that you talked about, Marcia, you talked about creating partnerships with political leaders, and how have you gone about forming those partnerships, and what do they look like?
Okay, so we use this legislative session as the door opener for creating those partnerships. And so we just basically went, knocked on the door. We took our information, our packages to people, knocked on the door and said, this is what's happening in Texas, and are you proud of this? I mean, do you want to do something to change this? We are in your community. We are on the ground. We're talking to people. We know that this is happening. Do you want to be a part of ending something like this? So it was just like basic, almost advocacy 101, where we literally empower people to go knock on the doors of their legislators and say, we voted for you, we will vote for you again, or we will not. But what we will not take is this. But surprisingly, with this maternal mortality issue, it was not that complicated. So many, even some of our legislators were not really clear that this was happening, but we still had those who were. And so we used the Texas Black Legislative Caucus to go down initially, and we invited all of our Texas Black legislators, and it's not that many of them, to come to a space and share space with us. And so we were able to talk to them about it, and so then they started to talk to their counterparts. We talked to some of the champions around in Texas, women and other legislators who championed issues that impacted women the most in Texas historically. And so we just created the partnerships using just very organic conversation and helping these legislators to understand that this is happening in your backyard. You're in Austin, but these women who are dying live in your district, and what are you going to do about it? We went in with the ask, but we also went in with the give, because we'll be your feet on the ground if you will move policy here. And so it was just kind of one of those. So we are still kind of figuring those relationships out, what they're going to look like. In the next couple of months, we're going to have a policy summit here in Texas, and also for all of the legislators that we've talked to. I mean, in Dallas, they want to be on board. They want to have conversation about it. They want to know what's happening on the ground. So we're still playing with it, but right now it seems to be working.
Fantastic. Thank you so much, Marcia. So the next question, I think I'll kick it over to Dr. Perry, but then, everybody can certainly weigh in. But this question is from Sam. And what can healthcare providers and members of the healthcare community do to help raise awareness and combat maternal and infant mortality?
So we're always amazed at how little even our own medical community understands or knows about how high the rates are in their own communities. And so being part of other organizations outside of the hospital, like your Healthy Starts or like the Boot Hill initiatives for infant mortality in St. Louis, I cannot remember the name of the one there, but making sure that you are not just inside of the clinical space, but bringing in some of these other organizations who are working on infant mortality to share data and information with you and with you, doing a grand rounds or doing like a meeting at the hospital so that they can every year understand what the numbers look like, where people are coming from, what kind of other social determinants are impacting their ability to have healthy babies. So the more that the people in the hospital know that, the easier it is for them to then be better providers of care for folks outside of the hospital system.
Got it. Thank you so much. Does anybody else want to weigh in?
Sure, I can. So this is Rob. Oh, this is Rob Turner again. One of the things that we talk about often that's really important for healthcare providers and individuals who exist in the healthcare space to do is take time, space, and energy to really look into your own implicit biases as a practitioner and work diligently to increase your cultural competency. It's very hard to work with a group of individuals who you know nothing about, and so work with whoever you can to consistently continue to educate yourself.
That's a great piece of advice. I often offer that same advice to activists, that you cannot you can't work to liberate and empower people that you're scared of and that you don't respect and appreciate. So thank you for that. So this next question is actually for you as well, Robert. So what obstacles would you say are most obstructive to your work? What makes your work in addressing infant mortality the most difficult?
In our area, the largest obstacles for our work exist in cultural norms, particularly with cultural norms existing within the systems. And then one of the other things that we have to deal with is a lot of high-risk pregnancies. 51% of the women who became pregnant in the Boot Hill of Missouri presented as a high-risk pregnancy. So those are just two of the larger obstacles that we deal with often.
Got it. Thank you. So I have a series of questions here, and it makes me think that I was remiss in giving each of the panelists an opportunity to talk specifically about your organizations beyond your infant and maternal mortality rate. So the first question for Marcia, if you could just give a quick overview of what the AFIA Center is and what your mission is.
So the AFIA Center is a women-centered organization where we take into account the experiences of Black women, and we create programs that strategically designed to address the harmful effects of reproductive oppression. So we do our work. We are an HIV. We started out as an organization that was centered around Black women and HIV in Texas, and so we expanded the way we did the work, and we started to do the work using a human rights and using a social justice and human rights approach. And so our goal is to end reproductive oppression for all women, not just Black women, but all women. And so not just maternal mortality, not just abortion. Our work is centered around oppression of Black women.
Thank you. And same question, different organization, to Dr. Joya Creer-Perry. What is the Birth Equity Collaborative, and what exactly is your mission?
Hey, great. Thank you. So you just call me Joya, it's fine. But so the National Birth Equity Collaborative aims to reduce Black maternal and infant mortality through research, family-centered collaboration, and advocacy. And our vision is that every Black infant will celebrate a healthy first birthday. We began about 2.5 years ago with initial funding from the Kellogg Foundation to interview Black women who had an infant death in 7 sites. And we created a report. The name of the report is Look at the Whole Me. We did about a 2-hour interview with them along with the Tulane School of Public Health. We created the Birth Equity Index, which has 100 cities where Black babies die or born and die. And it ranks them against social determinants of health. We found about 10 of them that have a positive predictive value towards infant mortality, including things like pollution. The higher your pollution rate, the higher your rate of Black infant mortality. And so we use that kind of framing to reframe the ideas around infant mortality from this like I said, a personal responsibility related to what is more human rights or social reproductive justice or system change.
Got it. Awesome. So thank you for that. And then finally, Robert, if you could just give the mission for Boot Heel Babies, and let us know more about what your mission is there.
Sure. The mission of Boot Heel Babies and Families is to reduce infant mortality through creating a culture of collaboration. So a little bit like what I talked about earlier is we pull everyone in. What we know about our area in specifics is that individual organizations and agencies were used to working in silos. We understand that infant mortality has been an issue in the area and has been for a long time, and that hasn't been working. So we adopted the collective impact model to attempt to attack infant mortality from a different angle.
Fantastic. So we are at time. So thank you to our attendees for their great questions. I want to thank each of our guests for just the wonderful work that you're doing and for sharing that work with us and with our attendees. And a special thank you to Ivania Woods for organizing this wonderful webinar for Reproaction, our Missouri organizer, who is also heading up our Missouri infant and maternal mortality work. So thank you, Eva. So without any more, so thank you to everybody. Please visit our website if you haven't. Sign up for our alerts, and we will send out a recording of this webinar at some point tomorrow. Thank you, everybody, and thank you so much to each and every one of our guests. Have a great night.